to you. On evaluation, you are seeing this.
There is some eminence posting in the base of the tongue.
Yes.
Is it, you have to first exclude lingual tonsil presence, lingual thyroid, and normal thyroid is ultrasound usually shows you it's an aberrant thyroid or normal thyroid in the unnatural location. I think that's thyroid intake is showing in CT scan. Majority of these patients will be having normal thyroid, maybe an aberrant thyroid.
So in these patients, you can actually, would you select an external procedure or can you do something internal?
If this is the only functioning thyroid and my CT scan tells me that this is the only functioning thyroid, I would actually try suppressive doses of aldoxin to see if the size actually shrinks. Or even the main complaint of the patient is multiple episodes of blood metastasis or things like that, and if there is, and the medical management doesn't seem to be working in reducing the size of the thyroid. Mind you, most of the times it does. If it doesn't, then you would have to go in and do. Earlier we used to do an external approach, but now with the copulation, I think it's a wonderful tool. We can do an excellent dissection.
Even if it is the only thyroid and if it is causing snoring and these things, the thyroid supplementation is the best answer.
After the excision,
Yeah.
so you can actually excise it and you can replace it.
Suppose you do a total thyroidectomy for any condition, you have a supplement beautifully.
All the patients would like it, sir. I think it depends on where you practice.
So this is one such patient for whom we did this excision, and you can see that we have kept the patient intubated for 24 hours and then did an endoscopy postoperatively, and then we saw that there was no bleeding, no edema, and then we extubated the patient, and we can pretty much see how the tongue is beautifully heals after 14 days and after a month. So that is the way. So now, if there is an epiglottic collapse as well as there is an external, you are running short of time. One question to you and you are done. So what are the indications for higher advancement?
Yeah. For me, higher advancement will normally, earlier I used to do it more often. Now, lower tongue-based obstruction, higher works beautifully. Lateral hypopharyngeal collapse, also higher works beautifully. And epiglottis obstruction, also higher. But now doing most of them move to endoscopic approaches. So those of you who don't have setups, like big setups and scale of endoscopic procedure, higher advancement is an excellent procedure. The postoperative edema is almost zero. You will get very good lower tongue-based advancement.
What is one advantage, one specific advantage of higher advancement over the tongue-based excision? That is the take-home message. See, if tongue-based excision you are just addressing in the midline, but as a hyoid you are pulling the entire assembly. So entire hypopharynx gets stiffened and open up. Of course, only for 0.5 to 1 centimeter, but still it is going to stiffen it in toto rather than the tongue-based excision that we are doing. It is going to address only the midline part. So that is one thing about the advancement.
So that's the thing, sir. Anything that is stretched gets loosed eventually.
Yes.
So,
I mean, he is saying in a good way.
yeah. Yes. So when there is not so much shear, it gets loose.
It gets loose and yes. The long-term results of hyoid advancement alone, if it is done as a standalone procedure, is about 40 to 60%, depending on the standalone. If it is combined with this, then obviously the success rate increases. And complications of the tongue-based procedures. So, yeah, I think we're going to move forward. Tongue edema, tongue change in taste because of. So now, how often do you get epiglottic collapse?
30%.
30%. Wow.
What the mind knows, the eye see.
That is a real high incidence, I would say. In Srinivas's practice, he is seeing 30% chance of epiclotic collapse. Is it always primary or is it secondary or
Primary, secondary put together.
put together? Okay. What is more common? Is it secondary or
Secondary is more.
secondary is more common? And if you see a secondary epiclotic collapse, would you combine the epiclotic surgery in the same sitting or would you wait
No,
or
I only take care of whatever is
causing
the
the
Whether it is lateral hypopharyngeal wall or is it lung base, you have to deal with that.
And what are the patients for whom you would select maximum advancement?
Maxillomandibular advancement actually is one of the best surgeries. It's got excellent results. More, if there is one surgery that gives as good results as CPAP, it is maxillomandibular advancement. You can actually extend your indications as far as BMI is concerned. And if you want to do the name, you can go above the 30 mark. Number one. If you see that the patient's maxilla is hypovolemic, if you see that there is actually the term used is increased craniofacial load. That means there's too much of soft tissue to the bone, so you can actually opt for a maxilla.
And the results
Results are pretty good.
80%?
90%.
in 1 year or 5 years?
This is in 2 years, I think. Yes.
And Parav sir, would you actually advise them for bariatric surgery as one of the treatment option or you would always try them for only CPAP or does it play a role?
CPAP definitely can be tried and it has different role. But ultimately, bariatric surgery, it is one something which will give us a very solid relief.
Dr. When do you follow these patients? What is your follow-up criteria? And when do you expect the result?
It depends upon the procedure we do.
Okay.
So, for example, if we are doing the parallel procedures alone, we get the 100% resistance after at least for a month. Once the healing process is over,
And
then we can
Srinivas,
know the result.
when would you do a sleep study on these patients?
3 months.
3 months. And is that it, or would you do again after every 6 months, or what is
Yes,
your protocol?
actually I have all the patients' data with me. I don't call, but my juniors will call, and actually the most important thing that they'll be checking on is their weight, because if they put on weight, or whatever your effort that you have done and the success that you have shown will just get washed out, and then they will talk so bad about you. The problem is that they have not adhered to the principles that we have advised them to, and then you will take the blame for it. So what we do is excessively call them up, find out how they are doing, have they put on weight, are they going back to drinking irresponsibly or no. So that's the...
Madhu sir, what is the tough question for you? What do you think is the future of this? Is it just what we have just discussed, or something more innovative is going to come in real short time, or do you think
The awareness and quantitative increase of the social life conditions, certainly this is going to be a subspecialty in India. And it is certainly going to be a big boost up for a number of us. The only thing is, you have to select properly. I would like to also ask questions. Just now I asked. There are so many postgraduates in budding engineering. Give us 1 or 2 good books which gives majority of the information about the OSCAs.
we'll do that?
Right.
I think Murali is here, who is the boss of all textbook collectors.
Yeah.
I think we have like 2 or 3 books that we can return. Obstructive sleep apnea syndrome is one of the best books, and I also know that there is Kenny Pan's books and
I mean, it depends on, if you want to really get deep into it, the Friedman's book is. Then there is a simple book was written by Fairbanks way back in the 90s, which is also pretty good. Fairbanks.
but
There is the new OCNA. 2016 December OCNA is dedicated to OSA. That's a fantastic book also, right from sleep study. 2016 December edition of OCNA. Come. It is It's come, it's released.
It's released. And Srinivas, what do you think is the near future technique that you can think of?
We are getting our implant, the hypoglossal nerve implant, which is basically the implant which would be pacing the sphenoglossus nerve. The research, it is now USFDA approved. Now it's in Asia, it's now become the mainstream of management in the US and Europe. Germany is giving excellent results. Patients are getting cured of this problem. Patients have doctors have 3-year follow-ups for these patients. No other procedure, just implant on the distal branches of the hypoglossal nerve, and it's like a programming thing. So every time the patient breathes in, you will have the stimulator in the intercostal muscle. Once there is inspiration, the genioglossus goes forwards. You can switch it on, switch it off. You switch it on in the night, and in the morning you switch it off. Otherwise, obviously, in the morning you will be black out.
But the only problem is the cost.
The
It
cost.
is so expensive. It's almost
$21,000 at this point. So we wait for Aragishri to reimburse it.
so with this we are looking forward for a much better future.
It's gone, sir. Palatal implants are gone.
Palatal implants almost gone. Almost
They're not everything.
and exit. So with this we are looking forward for a much exciting future for the management of obstructive sleep apnea syndrome. I know that the genetics is going to play a bigger role in the future, but once again, I think we have covered pretty much almost all of the techniques, and we have just given you a general idea how a patient should be evaluated, how they will be presented to you, how are you going to evaluate, how you are going to select a proper technique for that particular patient, and how you are going to discuss with those patients the results of this particular procedure and what precautions and what do's and do nots we need to do for these patients. Once again, thanks for the organizers for giving us this wonderful opportunity, and if you have any questions, please feel free to
Thank
ask.
you, audience, to actually be there at 4:20 on a Sunday afternoon. So, thank you, audience.